Good morning, everyone, and welcome to our interprofessional session, The Country Mouse and the City Mouse. I think this is a topic that this group feels deeply. We have two speakers, and they're going to be interchanging, and I'm going to introduce our first speaker, Dr. Blake Sandry. Blake is a pediatric nephrologist at British Columbia Children's Hospital in Vancouver, Canada, and a clinical assistant professor at the University of British Columbia. She completed a Master's of Medicine in Acute Kidney Injury and is passionate about preventative kidney health, in particular as it relates to long-term kidney outcomes in critical illness. She is originally from Australia and has run rural pediatric nephrology outreach programs in both Australia and Canada, as well as having the urban experience in Vancouver. And I'll turn it over to Jennifer.
Thank you. As she said, my name is Jennifer Youngeman, and I do come from rural Woolsey, South Dakota. If you blink as you're driving through it, you will miss it. So yes, I do come from a very critical access rural neighborhood. But Kelsey is the dietitian for the dialysis clinic in which I run, and she is also the owner and founder of 605 Dietitian LLC, a registered dietitian and certified diabetes educator serving healthcare settings across South Dakota and beyond. With a Bachelor of Science in Dietetics and a minor in health education from South Dakota State University, plus a dietetic internship at Iowa State University, Kelsey is equipped to meet complex nutritional needs in diverse populations. Through 605 Dietitian LLC, Kelsey collaborates with dialysis units, long-term care facility settings. She also extends her expertise to public outreach via speaking engagements, media appearances, and social platforms, promoting accessible nutritional education. As the driving force behind 605 Dietitian LLC, Kelsey is dedicated to advancing patient-centered nutrition care and empowering individuals toward healthier food choices. Welcome.
Okay, good morning everyone. I'd like to firstly thank the NKF for the invitation to talk, and I'm excited to talk to you with my co-speaker Kelsey about how we can manage different geographies in CKD. We have no disclosures. The learning objectives for today, firstly, are to design intervention strategies to deal with the individual nuances of care for challenges that our rural and our urban patients may face, and also to highlight a few centre and program-specific interventions that some healthcare providers have created to address these rural and urban challenges as models for care. So let's start first with the landscape and the problems. What is a country mouse? Well, there's actually no universal definition of rurality, and different countries use different definitions. So for example, the USA uses rural-urban commuting areas, which is a composite measure of the number of residents of one geographic unit that travel to a more urban or populated neighbouring unit for work. The European Union uses population density and geographic contiguity, and Australia uses the Accessibility Remoteness Index, which is based on road distance to population areas. And because different countries use different definitions, even similar studies across somewhat similar countries may not actually be comparable. And we know that about 43% of the world's population live in rural areas. So in North America and the European Union, it's about 25% of the population. But in South Asia and Sub-Saharan Africa, it's up to 60%. So why should we pay attention to the country mouse? Well, Indigenous patients already have higher rates of CKD and often live in some of the most rural and isolated areas worldwide. In the US, there is a higher incidence of poverty among rural children compared to their non-rural peers, and we know that lower socioeconomic status is linked with higher rates of CKD. In rural USA, there is generally a higher burden of chronic disease, all-cause mortality, and infant mortality. And in the Global Burden of Disease Forecasting Analysis that was published late last year in The Lancet, it was shown that CKD is predicted to be the second highest cause of mortality in the USA by 2050, only second to cardiac disease. So we're finally catching up to the cardiologists, but not at all in a good way. So, I'd like to put it to you to join us for a Slido question. So pull out your phones, scan the QR code, and I'd like you to write in some barriers that you've noticed that your patients face. And these may be your urban patients or your rural patients, and we'll just see what you encounter in your day-to-day work. Okay, great. Okay, wow, lots of things. So transportation is a big one. Health literacy, finances, poverty, no nephrologists locally, lack of primary care providers. So definitely looks like transportation, health literacy and finance are kind of coming up as the biggest ones, but lots of other ones as well. Weather, location, yeah. So you can see here lots of different barriers that our patients face. So barriers to care, particularly in rural locations, one big one that came up, distance. But it's not just distance, it's also the dangers of travel. So in Canada in winter, and I'm sure this occurs in parts of the US as well, you can get pretty bad winter storms, which actually close a lot of the roads and isolate patients from care. An additional danger in Canada, I'm not even joking, moose on the highways. Definitely have had patients have very close calls with some moose. Patients have difficulty navigating the healthcare system. They can have disrupted care. There's often variability in the local supports and resources, so what's available in one small community is not necessarily available in another. When people need to relocate for care to urban centres, they have dislocation from their home support structures. It's been reported in the literature that patients from rural towns often feel a bit of discomfort with the large, busy institutional structures of, metropolitan hospitals. And health literacy is another one as well. So patients who have less access to care, there's less opportunity for them to learn about their health conditions and health promoting behaviours. And so it can often be a bit of a compounding effect because then they're less likely to seek care and have less health outcomes. But what we know is that access to care is more than just geography. So Levesque and colleagues put forward this diagram as a way to conceptualise the different barriers to healthcare and how they interact. So on the top, we have the health service factors of approachability, acceptability, availability and accommodation, affordability and appropriateness. And on the bottom, we have the patient factors. So the patient's ability to perceive, seek, reach, pay for and engage with care. So we know rural kidney patients are less likely to be able to access care simply because of their geography. But what are the actual implications of this? So in Australia, it's been shown that the incidence of patients requiring kidney replacement therapy is actually 3.5 times higher in remote and very remote locations. In a study of 30,000 patients in Canada in one province, of those patients with an EGFR less than 45 mils a minute, it was shown they were much less likely to see a nephrologist and less likely to be on an ACE or ARB, and unfortunately more likely to be hospitalised or die. What about dialysis patients? So an observational study of almost 700,000 patients in the US showed that the incidence of kidney replacement therapy was higher in rural areas. It's also been shown that the prevalence of comorbidities in dialysis patients actually increases across the urban-rural spectrum. So the more rural you are, the more likely you are to have additional comorbidities with your CKD. Another study of, again, over 700,000 patients in the US starting hemodialysis showed that if you live greater than 100 miles from your hemodialysis unit, you have an increased risk of death with an adjusted hazard ratio of 1.2. Just across the border in Canada, a study of almost 27,000 patients in one province showed that those living greater than 300 kilometres who are on PD have an increased risk of death as well, so an adjusted hazard ratio of 1.15. But interestingly, it seems not to just be rurality that is driving this, even just travel time. So an older study, the DOPS study, this was a subset of these patients, so almost 21,000 patients who completed quality of life surveys, and this was across 12 countries. They compared patients who had to travel greater than 60 minutes to dialysis compared to those who travelled less than 15 minutes. And those who were travelling longer had significantly higher risk of death. They had more missed or shortened sessions due to transport issues. They had significantly and clinically significantly lower quality of life scores, but there was no difference in hospitalisation rate, dialysis withdrawal, or transplantation. What about transplant patients? And so this is all data that pertains to the US. In rural centres, less patients are expected to be transplant candidates, and following on from that, significantly less rural patients are on the wait list. However, rural patients do tend to be put on the kidney transplant waitlist faster. And once they're waitlisted, there is no increased wait for a transplant for rural patients. One study showed that actually rural patients are perhaps more likely to receive a transplant with an adjusted hazard ratio of 1.15, but an earlier study showed that Black populations living in rural areas are less likely to be transplanted than their city counterparts and less likely to be transplanted than any other group. So that's US data. What about overseas? So in New Zealand, living in a remote region was significantly associated with decreased timely waitlist or transplant. And in this publication by Birrell and colleagues from last year, you can see here that on the y-axis, you've got the proportion of patients waitlisted. In the red line is those patients who are living in a remote region far away from a transplant centre. And you can see here that it's significantly lower compared to the green line, which is those who are living close to a transplanting centre. Not far away from there, in Australia, they looked at paediatric transplantation, and they found that children who are living in remote or regional Australia were 35% less likely to undergo preemptive living kidney transplant. However, once they received a transplant, there was no difference in graft survival or in acute rejection. But it's not just our rural patients that face barriers to kidney care. So the 2024 US RDS annual data report showed that those living in the most deprived neighbourhoods, whether they be urban or rural, have the highest adjusted rates of incident end-stage kidney disease. So there's definitely challenges and barriers to health care in urban locations, and some of these include housing insecurity, pollution, lack of green space, transport, and lack of insurance. It's known that healthy built environments with green space and walkability are strongly associated with health-promoting behaviours by providing favourable venues for exercise, healthy food options, and sleep hygiene. This diagram from Kim and colleagues shows how the built environment, social environments, and ambient pollutions interact to increase and contribute to CKD risk factors, which then drive CKD incidence and progression. There's been studies from China and Korea which do show an association between reduced neighbourhood walkability and increased incidence of CKD. However, this hasn't been well studied yet in the US. And with that, I'd like to hand over to Kelsey to talk to you about some of the nutritional challenges.
Thank you. Like they said, my name is Kelsey Rabb. I am a registered dietitian, so I have a very unique perspective in terms of rural and urban areas. So in South Dakota, a normal commute for me, the shortest commute is 4.5 hours round trip, longest being 10 to provide nutrition care to patients both in dialysis and then also serving in more urban areas and a long-term care facility for our dialysis patients. So we drive a lot in South Dakota to go serve for our patients, but it's bringing that nutrition care to them. So very unique, but also eye-opening that that's how far we have to travel to provide care. So what are some of our nutrition challenges for both our urban and our rural areas? So these are some of the nutrition challenges for the urban areas that we see. One of them is being access and food deserts. So availability of a store. So in some of these rural areas, there may not be a grocery store available. They may be shopping at a gas station or a mini mart, or what we like to call our mini Walmarts, which are like Dollar Generals or those different stores. That's where our patients are doing a majority of their shopping, not only because of access, but due to costs and affordability of those food items. And do they even have renal-friendly, high-protein options at those places to purchase? You know, the cost definitely outweighs what they're going to be able to purchase there. Transportation is a large one. So is there a lack of transportation to go access those renal friendly foods? You know, there may not be public transportation that they can take to travel, or have a friend or family member to drive them to those larger areas to access that renal-friendly food items they would need. Of course, a large one is the financials, so the cost of that fresh renal-friendly food options, you know, it often has that higher price point of what it would cost, especially in our more both our rural and, you know, our urban areas. But for example, financials, so at the local grocery store where I grew up, they had iceberg lettuce. So essentially very minimal nutrition quality, right? But it's at least a vegetable. We're getting something in our patients. That head of lettuce was $10. So if I think back what it used to be, $1, you could get a head of iceberg lettuce, $1, $2, but no, $10. But then what are they going to have to put on that salad? They're going to put more vegetables, or they're going to put dressings or those kinds of things. And then we're upwards of $20 or more just to eat lettuce, you know. So this is where the financials, the access, it can be very hard for our patients. Food quality, again, that availability of those nutrient-dense, high-quality, renal-friendly foods. In these rural areas, by the time they get to those places where they can purchase those items, that quality is going to have diminished because it has had travel time, it has sat for a greater period of time, so we're not going to get that optimal fresh renal-friendly foods that we may in more of our urban areas. Our economical factors, so that creation of that food insecurity, more prevalent that we're seeing in the rural areas. And then other comorbidities we may see, the availability of food may be necessary to some of our other comorbidities, you know, that we may see other things such as diabetes, heart disease, that we all have to take into consideration when we're trying to feed our patients in those rural areas with that, and that's quite a challenge. So here are some of our nutrition challenges for our urban areas. So one of them is our access and food deserts. So not only in our rural areas will we see these food deserts, but also in our urban areas we will see them as well. And this is likely due to their access and availability to get to a grocery store, or the long distances we may see between them as to where our client or patient is living and where that grocery store or food source may be located. So that transportation, maybe they don't have the accesses to do public transport or have a mode of transportation to get them to those food sources. We also see urbanization, that affects of the availability of those high quality nutritious foods. So that can be a factor we see as well. Again, we may have access to a larger variety of more of those poor quality, less nutrient dense food sources that are going to be at a lower price point. So if we're already having those financial strains, what are we usually going to see? We're going to see higher costs of those low quality foods where we can really stretch our budget and get more food overall, but it's not going to have that higher nutritional quality that is going to be beneficial to that patient or client's long-term health goals. Other economical factors, we might see that creation of food insecurity. They're just simply not able to afford the food that they need to sustain them nutritionally. And then we can also see there's other comorbidities that availability of food may be necessary to their other comorbidities. So they're going to have more access to things. We may see that it's affecting diabetes, the heart disease, other factors as well. Okay, so I am going to turn this back over for some solutions, and we are going to talk about what are we going to do for solutions next.
Thanks, Kelsey.
Yes.
So before we dive into solutions that we're doing and that other people are doing, we would like to know, what supports does your program provide for rural patients? Do you offer things like virtual appointments or outreach clinics or travel support or accommodation support? Any remote lab testing, medication delivery? Okay, got answers coming in, good stuff. Okay, I'll give it a couple more seconds. Okay, let's see, what have we got? Virtual appointments, fantastic. So good to see that lots of people are doing that. Medication delivery, travel support, outreach clinics. Oh, okay, sorry, clicked early. So that's really great to see that people are really thinking about their rural patients and what they can do to help them. And so I'm here talking to you today because I work in a very large province on the west coast of Canada. So British Columbia Children's Hospital, which is in Vancouver, serves the entire province of British Columbia. And you see, you can't see my mouse, so where's the little clicker? So Vancouver is down here, right down here. And so you can see we have the rest of the province that we need to look after. It's almost 1 million square kilometres, or 360,000 square miles, and it's larger than Washington, Oregon, and California combined. Or if you're someone who's more from the south of the US, it's about 1.5 times the size of Texas. So we recognised that our patients were travelling really long distances to come and see us. And so we reviewed where patients were coming from the previous 12 months to see if we could figure out a way to make it easier for our patients. And as you can see here, most of the patients were coming from the Fraser region, which is about 1 or 2 hour drive to the east of Vancouver. And then following that, the next highest number of patients were coming from the northern interior part of British Columbia. And so after we learned this, we decided to set up 2 different outreach clinics. The first one is Surrey Hospital Outreach Clinic, which is in that Fraser Health region, so the first highest need area that I spoke about. And it's actually only about a 1 hour drive from the Children's Hospital, but there's enough demand that we have a weekly nephrology clinic there. And then the other outreach clinic that we do is to Prince George, and that's in this region up here. And that's in that northern interior health region, which was that second area of need that I showed on the previous slide. And that's a 9 hour drive from Vancouver or a 1 hour flight. And we do a monthly outreach clinic there. And so who is on our clinic team, our outreach team? There's me, the nephrologist, our nephrology nurse pictured here. We take our dietitian with us, and often we take one of our nephrology fellows too. The nephrologist, originally when the clinic started, used to rotate between the 5 different nephrologists, but now we just have one nephrologist, which is myself, going for better continuity of care. And our nephrology nurse and dietitian like it so much that it's been the same nurse and dietitian going for the past 7 years. This is the number of clinic visits that we've done over time. The clinic was started back in 2016. The orange is in-person visits and the purple is virtual. You can see here what happened in 2020. We weren't able to go very often, so we had to switch to virtual visits. And over time, we had kind of initially reduced the virtual visits, but when I took over the clinic towards mid-2023, I recognised that patients were still travelling a very long way just to get to Prince George, so I've opted to do kind of combined virtual / in-person visits. And so last year we got up to 100 visits for the patients. I'm assuming most of you are probably adult healthcare providers, so 100 visits is probably how many patients you see in a week. But in paediatrics, we tend to do things a little bit more slowly, so the average half-day clinic for us would be about 6 to 8 patients. What do patients think of the clinic? So one of the parents said to me, it's such a godsend being able to come to clinic here. It's okay going to Vancouver, but it's just so much easier with 2 kids not having to pack them up and get on a plane. We just pop into town instead. And the dad said, you know, it's overwhelming going to Vancouver when you're from a small town. It's so busy there. And you might be able to tell that one of my patients from the outreach clinic was just a little bit excited when I asked her to take a photo to share with you all today. So what are the benefits for patients and families? So obviously reduced travel time. There's also less family disruption. So there's not one caregiver having to go with the child, leaving sibling, other family members behind. There's less missed school, less work absences. People are able to stay in their home community near their culture, and there's less out-of-pocket expenses. But it's not just benefits for the patients and the families. There's other benefits too. So I've really recognised that there's increased collaboration with the local care providers. I've been able to meet the local paediatricians face-to-face and discuss patients with them. We've been able to help educate rural trainees who otherwise don't get much exposure to nephrology patients. Occasionally, actually, there's been inpatients admitted to the hospital that nephrology's been consulting on via the phone, and I've actually been able to review those patients, which the staff at the rural hospital and also the patients have found really reassuring and have quite enjoyed. It's really strengthened, I think, the patient and provider relationships. So we see these patients a lot more often than we otherwise would if we weren't doing the outreach clinic. And I think you gain a lot from seeing patients face to face. You know, people feel comfortable to kind of have a chat and share their life with you. People show me photos of all the salmon berries that they picked that season, or pictures of their new farm dog. And so it, you know, brings a little bit of joy to the work as well. Another thing that I don't think can be underestimated is this team bonding. So once a month with our dietitian and our nurse, I spend the entire day with them from 7 a.m. when we get to the airport to 9 p.m. at night. We have coffee together, we have lunch together, we have dinner together, and then we fly home. And I've gotten to know these people really well, and I think it's increased our working relationships, which benefits not only the patients that we see at the outreach clinic, but also that translates to the care that we provide to the children in Vancouver as well. One thing that I'm quite passionate about is the environment and how our kidney care and what we do impacts the environment. So, for example, when we flew up in March, 4 of us flew up, which is less than the 20 people minimum who would have come to Vancouver for the same clinic. As a result, we saved 1,870 kilograms of carbon dioxide emissions, which equates to a car being driven 13,000 kilometres. And that was just one outreach clinic. We've learned a few things along the way. So what's been helpful is learning what local services are available. So talking to the clinicians there, we find out what the hospital in the next town can do and what the lab in the little town can do. We've learned that one of the adult ophthalmologists is actually happy to see paediatric patients. one of our patients who was on tacrolimus needed tacrolimus levels, but the lab in their town only opened at 12 p.m. and was only open for a few hours. And we were able to collaborate with that lab so that on the days the child needed a level, they were happy to open early. And so I think that's one thing that's been really beneficial for us and the patients. We've learnt to respect the weather. So we used to run clinics in December and January, but we either got snowed in, didn't make it, or the patients didn't make it. And so we've learnt to just change those clinics to virtual ones instead. One thing that I've really come to learn is that Prince George, as I mentioned, is still far away for a lot of patients. Some patients are driving 5-7 hours, and so recognising that sometimes virtual appointments are better for them. And I have had to admit that the outreach clinic isn't actually best for all rural patients. So there are some of our patients who have really complex social work, urological needs. And so while we tried to make it easier for them, not having to travel to Vancouver, we actually recognised that we weren't providing the best care, and it was better for them to travel to Vancouver. While I do think the outreach clinic model has a lot of benefits for patients, families, and even staff, we do have to recognise that when we go back to this model about healthcare access, it's actually only addressing just a few factors, and we need to recognise that there is still a lot more to be done when we're looking at access to care for patients. So that's just one thing that our team is doing, but what are other people around the world doing? So somewhat similar to us, in Australia there's the Cape York Kidney Care Clinic, which is an outreach clinic up here in the far north of Australia. You probably can't see, but the next biggest town is down here, it's Townsville, and that's approximately 1,000 kilometres away from all of this area up here. They have a kidney care team that consists of a rural GP, a kidney nurse practitioner, dietitian, Indigenous health practitioner, and a pharmacist. So they don't actually have a nephrologist on the team, they're just supported by a nephrologist via teleconference. This team visits 6 different health centres, and 75% of the patients that they see are Indigenous, which is great because Indigenous Australians, much like other cultures, are at higher risk of CKD, so they're benefiting the Indigenous population and the rural patients. This clinic, they're able to run clinics 1 to 3 monthly at each site. In the first 12 months after they started, they saw 204 patients, and 180 of those patients hadn't been seen by a kidney provider before. There was a high prevalence of CKD stage 2 and 3, and a significant number of patients with proteinuria with a urine albumin creatinine ratio of greater than 30 milligrams per millimole. One additional kind of newish technology is home-based urine albumin creatinine ratio testing. And I think this is something that has the capacity to benefit not just our rural patients, but also urban patients that have trouble accessing care. So how does this work? The urinalysis test kit is mailed to a patient's home. They do the urinalysis at home. It comes with a little collection jar and the urinalysis stick. They then have their smartphone app which analyses the dipstick, and the patient gets the result immediately. And the result is also sent immediately to the patient's provider. This home urine test kit and the smartphone analysis app has received FDA clearance, but I'm not going to mention the company or the brand names until they start sponsoring me. So there's been a few studies that have looked at this home-based urine ACR testing, and one of them was conducted in southeast London, so a fairly urban population. And this was patients with diabetes who hadn't had a urine ACR in the past year. There were 13,500 tests sent out. About 6,000 tests were completed, so a 47% completion rate. But the authors were really good, and they looked at who completed the test versus who didn't complete the test. And they found that people were less likely to do the test if they were over 70 years, if they were in the most socially deprived quintile, and if they'd had no healthcare interactions for the past 5 years. So that asks the question, does this new strategy actually increase existing health inequities? And so I think it's really important that when we're adopting new technologies or new strategies, we need to look at who is this benefiting? Does it increase or decrease health inequities? Similar to this, a study was done looking at home-based UTI testing. So this was just a very small kind of pilot study in 19 patients who had recurrent UTIs post-kidney transplant. They evaluated how many UTIs occurred in the 7 months before and the 7 months after the intervention. During the intervention phase, there were 71 tests conducted when a patient had symptoms of a potential UTI. 47% of those tests were positive. And they reported that 50% of the patients who had positive tests receive antibiotics at home within 24 hours in the post-intervention phase. But they didn't actually report the time to antibiotics in the pre-intervention phase. And so it's unclear if this is actually getting patients antibiotics faster. What they did note is that during the pre and the post-intervention phase, there was a similar number of urinary tract infections per kidney transplant recipient, which is KTR. But they did see that there was a lot less UTI admissions per kidney transplant recipient and also a lot less complications per kidney transplant recipient. The one thing that they did notice as a potential negative was that the nursing time for each UTI episode actually increased by 15 minutes, from 30 to 45 minutes. One other project that I think is particularly cool that is happening not too far from here in Virginia is drone medication delivery. So this project is called the Elevating Healthcare Access Project, and it's a partnership of the Riverside Health System, Virginia Institute for Spaceflight and Autonomy, and a company called Drone Up. So the rationale for this project was that the pharmacists noticed a couple of things. So their older, frail patients were having troubles getting to pick up their medications. There was also a significant lack of public transportation in the area, and an area called Tangier Island. Patients, were at the mercy of the transport boats and the mail boats bringing things in. And so they started this project a few years ago. They initially did testing flights of just 1 to 3 miles, but have actually increased the distance of the flight up to kind of almost 17, 20 miles. They did a flight to Tangier Island just in October of last year that was successful. At the moment, they only have a limited flight range of 20 miles due to battery life. But I think over time, this technology will actually have the capacity to really improve patient access to medications. And so with that, I'd like to hand you back over to Kelsey to talk about some of the nutrition solutions.
Thank you. So these solutions to the nutrition challenges, I think, is the most exciting part about my job, is how can we help our patients, and what are some of those things going to look like in both those rural and urban areas. So rural areas, one thing that we have seen do wonders for some of our rural communities has been community gardens. So this has allowed there to be access and availability to that nutritious, high-quality food that would normally not be not only affordable, but accessible in some of those rural areas. Some of these rural areas, we don't have grocery stores. They're shopping at a convenience store. There may be no fresh produce available to them at all. And this community garden is bringing that right into that community, and it's letting them be a part of that growing process, nutrition education, learning how we take this seed and grow it into a plant and nurture it throughout this whole process. So it's kind of been that great opportunity, not only for our young individuals, but also our elders to kind of work together to collaborate on that nutrition education piece and really learn from one another how we get this garden to grow. It's also been that sense of community involvement, that empowerment, working together to see these community gardens grow. There's a few different types of community gardens, ones that we've seen that are sponsored, where it's one community garden, they will all work together, or ones will have lots where you can have a specific lot where you can have your own garden within a larger area. So if you want to plant or grow specific items, you can do that within your lot in the garden. And then it's also that intergenerational engagement, like I had talked about, working together, learning that growing process. Food pantries. So these food pantries, these are going to provide that essential food security. So I just got an update from one of my facilities that is in a very rural area, less than 1,000 people. They're a critical access hospital. They got notified that they are going to be able to put in a community food pantry into the hospital that patients can go in and access at any time. So it's going to be discreet. It's going to have that availability of those healthy food choices that anytime community members can come in and access those food items. This town does have a grocery store, but again, we see those economical limitations, high costs, low availability of foods. So I think this is a great thing that we're having this come into our hospital system. I've also seen this highlighted in South Dakota in churches and other local community organizations will have those very discreet food pantries that they're able to utilize for those food insecurity needs. Also, this really is that promotion of healthy eating habits. So we are going to be seeing them have the accessibility to foods they may have not tried before, those higher nutritional qualities that they can try out and have that experience of what those foods are for maybe the first time. It also gives us the opportunity to open that door to nutrition education. So we can highlight things such as posters about reading food labels in those food pantries or listing what are the food groups, so we can start to really educate our patients of, okay, yes, we have this accessibility of this food pantry, but what can we do for that next step? Can we start to provide the education to really help them have that next step of those learning tools? And then also we have access in our very rural areas with the assistance of a mobile food pantry. So in South Dakota, we have a mobile food pantry that I will share in a minute that will showcase, that goes into the very, very rural areas that have no accessibility to food, and it offers that opportunity for those healthy, nutritious foods. So this is an example of a community garden. This is from a tribal reservation in South Dakota, and this community garden will provide 20 to 30 families with fresh produce during the entire growing season. So this is actually from the reservation that I shadowed and did my practicum in my internship, and the dietitian was generous enough to share these pictures with me, but it has grown drastically since I was there during my internship, and it's just great to see all this wonderful produce that they are able to learn about that food and then also have that access to eat those foods. And this dietitian does Lunch and Learn series where she teaches the individuals how to make recipes with each and every one of these fruits and vegetables. So they're learning how to use the food in a nutritious way, and she takes into consideration not only our CKD, but our other comorbidities that can lead to CKD when she's preparing these recipes. So I think this is a really great opportunity that we have, and we have seen these community gardens in multiple of our tribal reservations, but also in other community settings as well. Some other things in our urban areas that we may see, mobile markets and food pantries is one of them. So again, having the access to that nutritious, high quality foods that would typically not be accessible in select urban food desert areas. So where we may see more of the packaged food items or the ready to eat items, we're now getting in some of those more high nutritious quality foods to where they're able to have a variety of options to eat. We have an effective and timely food distribution of larger quantities of individuals. So it may be where they're doing a mobile market or that food pantry, and individuals are coming to pick those up in boxes or certain areas and kind of work their way through that mobile market that we may see. Barrier reduction, so it's really helping to bring that food to them and to cut down on some barriers that we would see. And also it has flexibility in what is going to be distributed. It's likely not going to be those same food items. We're going to see variety, different nutrition qualities that we're going to see as well. Farmers markets and co-ops is another one. So this is a more economical option for those healthy foods. And we're seeing this increase in access to some of our renal-friendly, nutritious foods. So in particular, our fresh produce, that is going to be our more renal-friendly, so our lower potassium, lower phosphorus foods. We're going to be seeing that option for our patients to purchase them at a lower cost, where they may go to the grocery store and tomatoes are $5.99 a pound or $4.99 a pound. You may see in some of these areas, we may be able to get it at a reduced cost at that farmer's market, and the nutritional quality is going to be so much higher and better for those foods. It also opens that opportunity to nutrition education. So we may have dietitians that have presence at those farmers markets that are providing education. We also may have gardeners there that have master gardener certifications that are kind of able to teach others, okay, how can we start our garden in these urban areas together to kind of have that experience to grow those foods on our own, so we can provide those nutritious quality foods. We also can have that presence to also teach about the label reading. Like I said, that's a big one of, okay, how are we going to start these label readings? Because yes, it may be at a farmer's market, but it's important that they know those things, because what is the primary foods they're eating? And then also supporting our local businesses and just having that community member engagement, I think, is so important as well. So what does this look like? I always say I moved from very rural to what I call urban rural, where we live now. So I say in South Dakota, if you have a Walmart in your town, you are urban. So I live in urban rural now. So that was very eye-opening to me. But we have mobile markets is a big one, in food pantries. So this is Feeding South Dakota. This is our mobile food pantry that will drive across South Dakota, and it will go into our very, very rural areas with this mobile food pantry and make deliveries of foods. So both fresh foods and then also canned, non-perishable items, things like that. And there is a great variety of things that you will see. So these are just a few of the pinpoints as to where that mobile food truck will travel. They have a beautiful website that individuals can go on and look and say, okay, where is the next distribution site going to be in each of these given towns? Very user-friendly, easy to see. And then it's just an education piece of what can we do with that education. And then, so I think that's a great visual there that kind of shows where they do those distributions. And then farmers market, this is from our local farmers market in the town that I live in. Some beautiful fresh tomatoes there, and some other, they have wonderful opportunity for that fresh produce at a lot lower cost. And then we're also utilizing our local growers within the community. And it's just great to see that food being utilized without that travel time to get to the grocery stores and things. That quality is staying a lot fresher. So the big one I think of in terms of once we get into dialysis and we're having to start with nutrition supplementation, what are kind of some of those impacts that we can see? So access to nutrition supplements, I think about in our very rural areas. I just went to purchase Ensure Clear to go look at prices for some of my patients for a presentation I was doing, and 6 Ensure Clears was $13. Now, if you're going to recommend to a patient, we want you to drink, 1 to 3 nutrition supplements a day, and we can hardly have them affording nutritious, high quality food to eat for a meal, what are they going to pick between their supplement or their food? I want them to pick the food, right? I always say that food first, nutrition, supplement if we need to after. So how can we make those financial burdens of those nutrition supplements less? So we can do some nutrition supplement assistance programs. Companies are great with giving us some assistance, coupons, or giving them home delivery of supplements to their house to use if we're struggling with albumin levels on hemodialysis. Also, nutrition education. So by having a registered dietitian going into the hemodialysis units and educating patients in CKD before they start dialysis, we're able to use that opportunity to find alternative solutions to improving their protein status, their overall nutrition status, that we may not even need to use a nutrition supplement at all, which I think is a great thing. And then also doing some collaboration with our local pharmacies, our hospital systems, our dialysis centers. A lot of times they're able to get those supplements at a significantly lower cost that we're able to work through giving them the options that they need for those supplements if we do need to supplement with one of those nutrition supplements, in particular for the protein. Now, access to a phosphorus binder. So there can be a large financial burden of phosphorus binders. So we do have some binder assistance programs that we will use in hemodialysis. I think the biggest one that I like to speak on is having that nutrition education from that dietitian in the unit multiple times per month in our more rural areas, providing those alternative solutions. So it may be it was one specific food that this patient was eating every month that was causing that high phosphorus, that we can make some alterations to decrease that phosphorus. It also can be timing of binders, the understanding of, okay, when am I taking this medication? It's not descriptive on the prescription bottle of when I need to take this, the timing of it, that whole piece is very important. And then also utilizing telehealth opportunities. So utilizing what we have for insurance coverages within insurance companies to provide that education for our CKD patients. So I think about Medicare, we have opportunities when they're in certain stages of CKD through their post-transplant, utilizing that education as much as we can. I always say everybody can use a refresher course when it comes to nutrition. Just because you've had the education once doesn't mean we picked up on every piece of that education moment. I think it's good that we continue to use that and refresh that. I know I even have my dialysis patients, they say, okay, Kelsey, we've heard this from you for 7 years, but we always learn something new every time. You know, I've had some patients for 7 years and they still say, wow, they pick up on different things every time you're educating. So what might not hit them the first time, that second, third, fourth, fifth, sixth time, it might finally be that light bulb that clicks that education piece is working. So I think that's great that we have the opportunity to use that education for multiple years. It's not just at diagnosis. We can use it throughout the process too. And then also collaborating with our local pharmacies, our hospitals, and our dialysis centers for those phosphorus binders. Access to those binders, I had a patient, I think this is a very pertinent rural story. They were prescribed Tums for a phosphorus-based binder. Well, where do most rural people look to buy their items or medications or things? They went to Amazon. So they went for the cheapest Tums that they could find for the largest amount of volume. And we were wondering, why are the labs so variable from month to month? Did anybody take time to look at the bottle of what the Tums were to see the exact amount? It had changed every time because based on what was cheaper on Amazon, that's what they were ordering. So sometimes it was 500, sometimes it was 750. So it was really changing. And then if we just took that extra time for that education moment to really dive in and look, and that just is that access of, okay, we're very rural here. That's what was an option for that patient. That's how they got their medications, So I think just understanding how those can affect both our rural and urban areas. So kind of in summary for today, patients in our rural locations are at greatest risk for adverse outcomes through their CKD journey. Rural patients exhibit barriers to healthcare and nutrition that can also exist in our urban centers. And engagement in local communities, assistance programs, outreach clinics, and adaptation of new technologies may help to reduce disparities in care. So we will leave it up to questions now, if anybody has any questions.
I want to thank our wonderful speakers for their informative and humorous sharings today. If you wish to ask a question like this gentleman just did, go up to the mic. I am also monitoring questions in our online Q&A. So if you want to go ahead, and then I'm going to read one of the questions from the online version.
Great presentation. I'm Kevin Tucker from Boston, but I grew up in rural Alabama, and we ate organically, even though we didn't call it that because everyone had a garden. And there was a lot of canning and freezing food so that you'd have food to eat during the non-growing season, but it seems to be a lost art. Is anyone actually teaching patients, about how to preserve foods, canning and freezing, so they have foods to eat during the non-growing season?
Question is about canning and food preservation.
Yep, I can speak about that. So I would say it's definitely lost art or a dying art, but we do see some of our younger individuals, and I think there's a great program called 4-H where we're learning, where we're having this education moment where they can come into these classes, and we're seeing, these young, 8 to 15-year-olds learning how to can alongside, whether it may be an aunt, a grandma, things like that. I know personally, I grew up with a grandma and great grandma who canned everything. We learned how to make, grape jelly. We were making pickles, all those things. I would say it's definitely something that we are losing but I think it's wonderful opportunity that we can have to, if we have these community gardens, to preserve those foods, but doing other things as well, such as doing those flash freezing and then freezing our foods within the putting them into the freezers, using those other mechanisms as well, I think is very important. But then also providing that nutrition education piece on safe canning, because there is a lot of risks of foodborne illnesses and other things if we aren't canning properly. So whether we're doing the water bath canning or we're doing other preparation methods, we really want to make sure we're giving that education piece.
I'm going to read one of the online questions. Has the recent ruling regarding payment by Medicare for televisits affected people's ability to do remote visits?
So I'm guessing this one maybe is for me. So I'm practicing in Canada, so not as up to speed with kind of Medicare payments in the US. But I think, anytime we take away Medicare payments for televisits or reduce those, then we're really impacting access to care for people that live more rurally. And so I think we as health practitioners, when these things are up for debate, we need to kind of stand up and advocate that it's for our patients, that really this is going to patients are going to lose out if these payments are taken back. It's not providers who are losing out, it's patients.
While we're waiting for someone to come to the microphone, I'll read another online question. What are the costs of the at-home UACR testing? I think this is for Dr. Sandry.
So unfortunately, I can't give you the exact specifics of the testing. From my understanding, some programs in the US are actually using them, but insurance companies are kind of footing the bill for the testing and sending them out to patients.
Okay, go ahead.
Hello, my name is Asia, and this is kind of a follow-up question to the one about telehealth and televisits, just because of some of the conversations in the news about, seeing how vital it is. I just wanted to know how much of the population of rural communities actually maximize those telehealth visits. Dr. Sandry, it's a question for you.
Yeah, so I think at BC Children's Hospital, probably somewhere between around 15%, I think, of all of our clinic visits are actually virtual. So definitely at our institution, a large proportion of patients are accessing virtual visits. What we do find, though, is that some of them even have challenges accessing virtual visits. Some of them live incredibly remotely and either don't have Wi-Fi or don't have telephone reception. And so trying to figure out a way to conduct a virtual visit for them can sometimes even be challenging. And so, we have to be very specific with each patient and know, okay, well, they live in this area and they they have Wi-Fi, but they don't have telephone reception. Or the flip side, this patient, we know they have telephone reception, so we call them. So in Canada, definitely, at least in our department, we're using a lot of virtual health. I think sometimes providers feel a little bit of hesitation in not seeing their patients physically, not being able to examine them, or not getting a blood pressure, not getting heights and weights. But what we found is that if we, instruct the patient a few weeks beforehand, like, oh, can you go to your either local pharmacy or local primary care provider, get a height, weight, blood pressure, and then they bring that information with them to the visit, I've actually found it works really well. Oh, the only thing is making sure that your patients are not doing their grocery shopping or driving while they're doing their telephone appointment. That's definitely happened, and I've had to reschedule.
I know with my family, we have to go to our center once a year, and the rest of the time we're allowed to do telehealth. But we live in a different state, so we're supposed to drive across the border to meet with our provider in the state that they're actually in, and that is a barrier for us. And so that is something U.S. clinicians need to think about because of licensure. Please go ahead.
Hi, thank you so much for a wonderful talk. So I'm Michelle Estrella. I'm from San Francisco, and we have a practice where we have a remote clinic where we go to about 3 times a month, and then telehealth as well. I think one of our difficulties in our experience has been just accommodating the number of patients who prefer to be seen in person, at close to home. And I was wondering if you've developed a way to, I guess, maybe protocolize or, some sort of algorithm to triage who's appropriate for rural, sort of close to home in-person visit versus telehealth in your practice.
Yeah, I think that's a great question, and I think that's really challenging. We don't have a protocol per se, but I think we do it kind of on an individual basis. Like, what do we know about this family? Are they someone who's really going to struggle getting down to Vancouver, or are they someone who actually their health condition is not too, I guess, complex, and they're more likely to be easily managed in a rural location? I think some of our really complex patients, like I've mentioned, we kind of triage them down to Vancouver. And for example, at the moment, we're not seeing our transplant patients in the rural clinic just because they don't have access to all of the, allied health providers, so they're being seen in Vancouver as well. But definitely that's something that I struggle with as well. We only have maybe 100, 115 in-person clinic spots a year, and how do you optimize those spots for patients? It's definitely a struggle.
I'm just going to mention we are 3 minutes over time now, but our next thing doesn't start till 11:30. So if you need to go, by all means, nobody will be offended. But we will just continue to take a few questions for those who are interested. One of the online questions that we are getting, have you had success increasing access to telehealth in remote areas?
I can speak kind of on the nutrition piece. So one thing we did, this was both when I worked in kind of our urban areas, but also now in rural, is we actually have, I applied for licensure in multiple states. So I'm not only licensed in the state I am, because we have to be licensed in the state that our patients are in. So it's allowed us to provide the opportunity for those telehealth remote visits, and then also using different online platforms for that, that are very, very user-friendly for doing telehealth visits, both within the hospital systems and then in private practice as well. So I also, within my private practice, I have the ability to use Calyx, which is a telehealth platform, and it's very user-friendly. They can use it from a phone, from their computer, and they're able to get that education piece as well. So, and then it's just educating the providers of, yes, I may only be at your facility 1 time a month providing nutrition education, but that doesn't limit us to seeing patients. I am available the X, Y, and Z these times to do those telehealth remote visits. So a few of the hospital systems have granted privileges for me within that system to use their telehealth software that providers would also use. So I'm able to do those nutrition education visits. And I think it's really helped. Otherwise, they may have to wait a month to get in our bigger towns with a dietitian, but they are gonna have to come back on a different day to see the nephrologist, a different day to see the whole team, where we can do it in kind of bits and pieces and kind of fit it into their schedule. So they're gonna have that access to that nutrition education that they need. So I think that's really great.
We have 2 more questions that I'm going to read, and then if there's a burning question from anybody here, we'll take it, but then we're done. There's a concern about patients with genetic rare causes of kidney disease like cystinosis in rural areas. What is the risk that they might die before they are identified?
So I think that's a great question. Patients in rural areas, like we've been talking about, have reduced access to care. But I think, at least for me where I'm practicing, we have, I think that we have enough coverage of British Columbia that we kind of pick up these patients. I think what's challenging is with virtual care and outreach is if you are only doing virtual care, then that's where patients can kind of fall through the cracks. And I think probably a lot of you will have had experience possibly with COVID, where patients really were maybe seen virtually for a very long time, and then they came in and, you know, I've had stories of patients who were seen virtually, had abdominal pain, and it wasn't so bad. Actually, they was finally seen in person a year later, and they had an intra-abdominal malignancy. And so I think virtual care is great, but we can't use it to substitute in-person care.
I should have mentioned earlier that we were to remind everybody that you do need to do all your evals and pre and post tests by May 29th to get credit. So just keep that date in mind if you don't choose to do it immediately. And I'm going to read the very last question. Why are rural patients put in transplant wait lists faster than urban patients?
So it's thought that patients who are more rural have, as we mentioned, have more challenges in actually just getting to their dialysis sessions. And so as a result, they're more motivated to get onto the transplant wait list faster because going to dialysis is so much more of a hassle. So it's thought that there's slightly more motivation to get off dialysis.
Thank you again for your attention today, and thank you to our speakers for a wonderful talk. Have a great rest of the NKF meeting. Thank you.